intro card, but first, this never happens. These conferences never happen without a lot of hard work from a lot of people. And we have a planning committee that's listed in your spiral binder. These folks worked really, really hard and not only came up with innovative topics and ideas, but worked very hard to get attendees to come to the conference. And of course, I wanted to thank my own staff, Barbara Giles, who you met downstairs, the silver-haired lady, registration booth. If you have any problems, any questions, any issues, she's the one to go see. Mark Johnson, who is responsible for a lot of our audio visuals and our tweener slides and the brochure and the flyer and a million other things. Tressa Carr from the VA, Veronica Salazar from the VA, and Joe Zapata. So thank them, and let me go get my really cool Mark-designed intro card for our keynoter, and I'll be right back. Dr. Amy Slonim is the CDC AARP liaison, functioning as a conduit to enable the two organizations to work collaboratively on an array of health and prevention issues and activities. From 1999 to 2007, she was Director of Programs at the Michigan Public Health Institute and Senior Public Health Advisor, acting as a Special Assistant to the Michigan Chief Administrator for Public Health. Dr. Slonim is a recipient of an Outstanding Leadership Award from the National Association of Chronic Disease Directors. Throughout her career, she has had experience in program management, policy development, applied research, program development, and evaluation. Dr. Slonim's experience working with CDC's Healthy Aging Program and AARP on maximizing health in the boomer generation makes her a natural to keynote the 31st Annual Conference on Aging with CDC Report, Promoting Preventive Services for the Boomer Generation. Dr. Slonim.
I am, sounding very loud. I am very pleased to be here with you all today. I was in Jackson, Mississippi, and I learned that the plural of y'all is all y'all on Monday. So I think I said it appropriately. First of all, I want to say I'm hoping that the next 50 minutes are a discussion. So please ask questions. The whole goal is for you to become familiarized with the resources that we have put together around promoting preventive services. So ask questions, because we'll try not to hold them to the end, and I know I'm watching time, we'll get through it all. I thought I might start out by just telling you a little bit about my position, which is new to CDC and AARP, because it will lay the foundation for why prevention has risen as it has and preventive services within AARP, and address a little bit of CDC's interest. So for many years, CDC has what they have called embedded individuals in federal agencies. And they found that that has been very helpful to help both organizations become much more aware of the day-to-day and working together and collaborating day-to-day. What they hadn't had was embedded individuals in private sector organizations. And for about 7 years, AARP and CDC had been working on an array of discrete projects around driver safety and trying to share research and physical activity in communities and preventive services. And some had gotten more traction than others. The preventive services arena had not gotten much traction. About 4 years ago, they started thinking, well, if the embedded person had worked in federal agencies, what if we had the same in a private sector? So they started this position. I work 3/4 time, and my role is, as much as you can in huge organizations, to be a conduit among both organizations and specifically on targeted projects. So I work very closely with the Healthy Aging Program at CDC and with the Education and Outreach arm of AARP. AARP does very thorough research on areas that they decide to embrace as part of their social impact agenda. And for many years in the healthy behaviors area, it had been wise use of medications and physical activity. And about 3 years ago, they decided to take on prevention much more fully and put together a whole 10-year plan. And that is when I started working with them. So for the first 5 or 6 months, it was just pulling together a big plan for AARP around prevention. And one of the key areas that has now risen to a social impact agenda priority is preventive services, because they recognize that this is a huge area for the 50 plus and an area where we can make a big difference. So my plea here today is be thinking creatively throughout about ways that you can engage and play a role in promoting preventive services for the 50 plus. So ask questions along the way. I hope that this will spark some thinking on your part, and certainly opportunities. And I'm here for most of the day, so okay, I was so pleased to know that Barbie even has circles under her eyes. Just to get you thinking about the boomer generation, let me ask a question. How old do you think the first Barbie would be today? What were the? 53. Any other? Do I hear anything else? 65. What was that? 60. Barbie would be 51. She was born in 1959. I did get my first one in 1960, and I was pretty close. Okay. How about G.I. Joe? I also saw him on there. Anybody know how old he is? What was that? 55? He's a little younger. He's 46, born in 1964. So we're in good company, and these are among our more popular baby boomers. Just as an aside, as I said, AARP does a lot of research. One of the things that you should know is that no one thinks of themselves as old. 60-year-olds always look to someone 10 years older as being old. Even 85-year-olds don't think of themselves as old. They think of 95. It's always 10 years beyond the road. So none of us are ever going to be old. Now bringing us closer to my topic, let me just say that I am so pleased that Texas invited us to be here. Texas is a huge opportunity around preventive services. What percent of the total population 50 plus lives in Texas? 7%. What percent of the 50 plus Hispanics live in Texas? 20%, that's right. So huge, huge opportunities. I call this slide Marching Towards the Silver Tsunami, the slow motion demographic tidal wave that starts to crash next year when the first baby boomers turn 65. By 2015, 1 in every 5 Americans will be between the ages of 50 and 64. As they enter the 6th decade, 70% will have at least one chronic condition, and 50% will have 2 or more. That's a little frightening. But the good news is we can do something about it. That's what I'm here to talk about today. So we want people to enter these ages healthier. I think this picture really just is a good illustration of that tsunami this shows the wave quite well. One of the things I wanted to do is run through a few more stats just to lay the foundation about the 50 to 64-year-olds. And you can see in this in this slide that in 2006, the 50 plus made up 40% of the population, and you can see the breakdown. But as that tidal wave hits, those proportions are only going to grow. And if you think this is only a problem of the South, although 36% of the 50 to 64-year-olds live in the South, it's of concern to every region in this country. Everybody has reason to be concerned. And with this slide, all I wanted to illustrate is that you can see that there's more ethnic diversity in the younger years, but we're moving in this direction so that those proportions will grow. What I thought I'd do is ask you to take out a copy of the book, because let's walk through it. This previous slides make it very obvious why CDC, and I told you why AARP, But AMA was the third group that provided leadership to the development of this report. And AMA recognized that they could not provide preventive services alone in the clinical setting. They weren't making it happen. So the three organizations were the primary leaders in the development of what they consider this to be a landmark document. It provides a baseline of summary national and state-by-state data to help monitor progress and to promote successful strategies to facilitate increased access and use to preventive services. The hope is that it will spark sustained focus on collaborations to promote preventive services. We only benefit from us all working together. So let's be thinking about that. We always wanted it to be more than a data report. We know how important data is. If we don't measure it, we don't know it. We can't bring it to the forefront to others to become aware. We can't monitor our progress. We can't make changes in programs from the learning. So it's very important to have the data to measure. What I'm going to do is start out by reading a quote that is in this report, and it came from yet another wise past president of GSA, John Rowe. It's a story he told at a conference many years ago, and one of my colleagues remembered this tale, and I am going to repeat it. In the midst of a typical seasonal flu epidemic, an extraterrestrial being walks into a hospital ER teeming with acutely ill older adults. Turning to the head nurse, he says, "There must be no prevention for this illness." She replies, "We have an effective vaccine." "Then the vaccine must be in scarce supply." She says, "Oh no, there's plenty of it. Look over on those shelves." Puzzled, he suggests, "Well, it must be very expensive." To which she says, "No, it's very inexpensive and often free." He replies, "Well, can you explain to me why you don't prevent this disease in these people?" And to that, the nurse replies, "No, I can't. I just can't." So let's hope the next time an extraterrestrial being enters a hospital, the situation is not the same. We can do something about vaccinating individuals. With this in mind, we'll turn the pages of the report. We not only had the three organizations that I mentioned, CDC, AARP, and AMA providing leadership, but we had a very engaged steering committee that represented organizations with intelligence around the data, as well as organizations that had constituency that could help implement collaborations and would find the information very useful. So you can see the array of partners that we had, that from the Agency for Healthcare Research and Quality to the Association of State and Territorial Health Officials, the National Association of Area Agencies on Aging, the National Association of States United for Aging and Disabilities. We've had a name change since the report. The Preventive Health Partnership, National Association of Chronic Disease Directors. And this wasn't just a steering committee that met once. They were very engaged. We met several times. It took 2 years to evolve this report. It was released last November, but it was a very long process. And we view it as the first in a series. And we're just about completing the next one, and I'm going to tell you about that at the end. And it's been much faster because we laid the groundwork with very thoughtful decision-making and processes in the first report. All the partners agreed that as a nation, we do an excellent job of ensuring that children are up to date with recommended preventive services. We have no similar mechanism for adults that we do for children by making immunizations a condition of entry to school. So therefore, it's a little more difficult for us to assure that they receive the preventive services. Further, the steering committee recognized that we can't solely rely on the thinly stretched healthcare system to do it all. We must work together to reinforce and bolster efforts by strong linkages among community partners, clinical partners, through policy, and through supportive environments. Thus, the steering committee agreed on the overarching goal of this report that would highlight summary national and state-by-state data to facilitate access and use of preventive services in community settings. The focus would be on the 50 to 64-year-olds, those not Medicare eligible. And when this report was started in 2007, health reform was not in the offing. The report was meant to be a complement, but not overlap with efforts focused on clinical performance measures. And it was a very thoughtful process was put in place for determining which indicators would be the focus. How many of you have ever used, seen this report, State of Aging and Health? Well, I'm hoping I can familiarize you with several resources. Oh, this is a great report that was started in 2004, and it was through a partnership of CDC, the Gerontological Society of America, and the Merck Foundation. And it is filled with wonderful data about the 65 plus. And it's not just preventive services, it's an array of health data. And it's also, there's an interactive version on the CDC website. This report had gone through a great deal of usability testing and had also had a lot of thoughtfulness in its development, and it became a model for the report that I'm telling you about today. It was focused on data for action, so not only was it demographic information, but it highlighted the challenges and ways that states had overcome the challenges in promoting activities that would enhance areas that were highlighted. And it was very much focused on being a useful tool to both public health and aging services agencies. And as I said, they have an accompanying website that also became a model for this report. Our steering committee agreed on 4 key principles to assist in the decision-making and content of the report. The first was it had to have a firm grounding in science. And we used the U.S. Preventive Services Task Force A and B recommendations, the Academy of the American Committee for Immunization Practices, or is it Academy? And the Community Guide, the CDC Community Guide. We had an emphasis on the decision was made to have an emphasis on primary prevention, and that the approach would be a community or population-based approach, not individual, not treatment. And we also agreed that in both the data that we would highlight and in the way that we would share the issues, we would focus on disparities and gaps. When thinking about who and how the report would be used, we thought this would be we wanted it to be a great tool for individuals offering programs to use both in grant writing and thinking about development and implementation of programs. We thought it would be a great way to educate policymakers and could be used to educate the media, and also could be used, as I said, in grant writing and report writing. And thus, we thought of the primary audiences as aging services professionals, public health professionals, clinicians, mental health professionals, and researchers. Among the important features of the report, above all, we wanted it to be easy to use. And we did some usability testing, and we also relied on the usability testing that had been done on the state of aging and health. We wanted to make sure that it was very useful to states. So there is, I'm not going to steal the thunder, but we wanted to make sure it was useful to states and that there was summary national data. We wanted to include things that would be catalysts for action. So we spotlight evidence-based programs and also activities that are going on in the organizations that we're partnering with. And we had calls to action that could be used to help not only in implementing programs, but to educate policymakers and actually have incited action and activities in the primary organizations, and I'll tell you about that as we continue through. The steering committee also wanted to make sure that we had some way to encapsulate the respective contribution of both the health system and the community that would be affected by the outcomes. So we embraced the expanded chronic disease model. And you can see this is a wonderful pictorial of how we saw them coming together and actually influencing change. So you're going to wonder, how could we narrow down the multitude of indicators that exist to assure that we would have, we had thought through why we included what we included. So as I said, the folks that, obviously the recommendations had to apply to the 50 to 64-year-olds. We wanted to make sure that somehow they could be linked to evidence-based community practices, so that there was something you could do about it, and that the burden and the significance were particularly relevant to the most vulnerable populations. And that, again, we knew that there were actions that could be taken to overcome the low rates that you will be seeing. And finally, we had to have enough data so that we could accurately portray it. So we had to have data from 35 states, and that did narrow the field. So let's now open your book to page 12, because it's very difficult to read this slide. And you will see the list of key issues and indicators that we included in this report. Most of the data from the report are for 2008, but not all of the indicators were collected in those years. So the depression data came from 2006 and the cholesterol from 2007. We included 4 screenings: breast cancer, cervical cancer, colorectal cancer, and cholesterol, 2 immunizations, influenza and pneumococcal, and 6 risk factors: no leisure time physical activity, being a current smoker, binge drinking within the past 30 days, obesity, high blood pressure, and moderate depressive symptoms. We also had 2 composite measures. How many of you are familiar with composite measures that help you look at many things at the same time? I am getting the one. So we wanted to have something, because we viewed it as an opportunity to be able to characterize generally how adults were doing. It's rather similar to the up-to-date measure with pediatric vaccines. So because of the data, we could include 4 variables for women, which were influenza, breast, cervical, and colorectal cancer screening, and for men, influenza and colorectal cancer screening. And what would you guess would be the rate when you put those together for men and women of generally how many, what percent are getting all of those preventive services? What would you guess they were? What percent of the population 50 to 64 in the US are getting all of those services? Just throw out a number. 50%. 20, 50, 30, up 10. All good guesses. 25.9 for women and 26.5 for men. Now, what would you think the composite measure would be for adults that are eligible for Medicare? And most of the screenings and vaccines are covered. What would you think it would be then? What did you say? Oh, less is a good guess, but it's 40. It's about 40%. But still, look at the room for change and the opportunity to help individuals get these screenings. So again, the composite measure just helps you not to individually look at them, but collectively, so you have some way to characterize how we're doing it. Also, we tend to have those that worry about immunizations in a community, those that worry about cancer screenings, those that worry about cardiovascular, and it's a way to bring them all together in a community to think collectively about promoting preventive services together. So it's a wonderful tool. Let's just think about where do you think we'd have the highest number of individuals getting the preventive services? I will tell you some of them are in the 80%. Where do you think that would be? Which preventive services? Among this list, take out the composite measure, where do you think we're doing the best job? I'm sorry? Cholesterol? Absolutely. 89.7%. What's another one you think would be high? Breast. Yep, 80, exactly, 80.3. Where do you think we're pretty low? Colorectal, we are at 53.3 nationally. I mean, huge room, and it is a focus of emphasis for CDC. We'll go through these, but all the data on the national summary is in there. Now let's turn to what we did was we have a national summary for all of them, but we feature each of these indicators in the book. So here is an example, if you turn to page 21 of an indicator page. We feature the indicator and tell how it was measured, and then we feature a section called Why This Matters, which is a couple of bullets that you could well use to document why this is the significance of this issue. If there's any cost effectiveness data, it's highlighted, and we always include some information about the most vulnerable. So let me just share a few of the Why This Matters data from some of the indicators. For cervical cancer, 50% of the women who develop cervical cancer have never been screened. 60% who receive a diagnosis have not been screened in the previous 5 years. Colorectal cancer, when detected early and treated properly, 5-year survival rate is 90%. It's estimated that if everyone 50 plus screened regularly, as many as 60% of the deaths could be prevented. That's huge. Hispanics 45 to 64 are at highest risk, at high risk are 1/3 less likely than whites to receive pneumococcal vaccine and 25% less likely to receive influenza vaccine. Now think about your stats in the state of Texas. You have a big opportunity there. So you can see that we provided easy data. We worked with experts in each of these areas, and we have well-referenced bullets that you can use to justify the importance of this issue. Then on the next page, we feature some behavioral risk factor surveillance survey data. How many of you have used BRFS data ever? Well, I'm going to acquaint the rest of the room with this opportunity because it is so easy to access and take advantage of. But it's a national surveillance system that is conducted in every state, and we used that data for this report. And we feature a map or a graph that highlights the percent receiving the vaccine or screening, or highlights some of the graphs highlight those that are insured and uninsured and who's getting more of the service or vaccination. So, and then we provide bullets that help you understand what the graphic is, and also a comparison to the Healthy People 2010 data in each of these. So it's all there for you to see. In colorectal cancer, what the BRFSS data show that you're not seeing here, this is the influenza. Hispanic men and women are less likely to report getting screened than white or black adults. The white women get about 55% are getting screened for colorectal, and the men it's about 56. Among Hispanics, men it's 38, and for women it's 41. So again, this highlights where there are opportunities to make a big change. You'll also note in the report that we wanted to make it very easy for you to think about your state. So we highlight a pull-out chart of the state-by-state data. You can pull it out. It's in there, tucked in, and it has all the state-by-state data. We were hoping someone might even want to laminate it and put it up in their office, but it's a wonderful reference for you. I have to tell you though, when you're looking across the states, you can't compare and say we're significantly different without looking at the confidence intervals for each of them, because if there's any overlap, they are not statistically significantly different, and we have that in the appendix. So again, wonderful tool, but be sure that you're accurate in how you portray how your state's doing compared to other states. So, do you want to think a little bit about Texas and how you're doing? Did any of you look at that? Just quickly look at the column. You can see for mammography, you're about 74.4, colorectal 46.3, influenza 42, pneumococcal 33. In your up-to-date measure, you heard what the nationals were. You're about 24.7 for women and 24.5 for men. Those individuals with no leisure time physical activity, 32.4%. You are, that's in the lower 10 states. Big opportunities there. You're also in the lower 10 on depression, 10.7. Not to point fingers, just to point at opportunities. I'm going to skip through this. Okay. If you look at page 3, we have a summary of a state-by-state picture. And we use the Healthy People 2010 targets, which are a set of health objectives for the nation, for 10 indicators that have such targets. So let's just quickly run through here. Mammography, 50 states and DC met the target of greater than 70%. Cholesterol screening, the same. Different target, but the same. Binge drinking, 45 states met the target. Colorectal cancer, 33 states met the target of greater than 50%. It still leaves a huge margin. So those are the 4 where we're doing pretty well. The next 6, Pap test, 5% of the states met the target. No leisure time physical activity, 4 states met the target. Smoking, 1 state met the target. Influenza, 0 met the target. Pneumococcal, 0 met the target. Obesity, 0. So, as a state, you're not alone. There is, as I said, much to be done. So that's the data end. We also sprinkled throughout the report what we called calls to action. And these were to help catalyze efforts. Once you read the data, what should I do? So these were designed to catalyze efforts to address what we call the opportunities to make a difference. There were only 6. Several of them are based on the community guide and things that are in the community guide that are evidence-based, that you can make a difference around binge drinking, tobacco cessation, and physical activity. But 2 in particular relate to, one relates to surveillance, which the first one relates to social determinants of health, and what it does is encourage states to collect data so that they will have those determinants to compare with and better understand the fullness of the lives of individuals who are not getting the preventive services. Last year, CDC initiated a module for the Behavioral Risk Factor Surveillance Survey that was based on the WHO Commission of Social Determinants of Health. It's 6 questions that allow you to get a better sense of housing access and access to nutritious foods, financial security, and the time at work and participation in civic activities. So there is an opportunity to collect that data. The last call to action relates to policies that may make a difference in the ability to provide preventive services in community settings. And AARP and CDC have collaborated since January of last year on an effort to define a handful of policies that may make a difference and that could be applied in local, state, and national setting. We spent 4 months doing expert interviews with 25 individuals. We're going to initiate a Delphi process with experts across the country to come up with a very concise list of what are those policies that could enhance the ability to provide preventive services in clinical settings. And let me just give you an example. There are several election board regulations that limit the possibility of co-locating the preventive services where in polling sites. So if you wanted to be able to give vaccines in polling sites, there are places where there are limitations. So we've commissioned a legal analysis of that to better understand it, so we can support those communities that want to be able to offer vaccines or preventive services in polling sites. I'm going to quickly go through this because I'm realizing I have 15 minutes. There are another section in the book on page 41. It's called Additional Issues on the Horizon. And we recognized we couldn't cover every preventive services, and there were many that were very pivotal to the quality of life and health and well-being of individuals in this age group. So we highlight them in this section and bring to the forefront issues of that might be important when you think about future surveillance. On page 46, we highlight a sampling of related efforts that our partners were undergoing. Let me just tell you about two quickly. The National Association of County and City Health Officials has a website that is a searchable collection of best practices going on in states. So there are opportunities to learn from those that are offering preventive services in community settings. And the Agency for Healthcare Research and Quality has a web-based innovations exchange. So both of those are great websites, and the websites are listed there. I mentioned that we wanted to highlight exemplary activities in community settings. We also wanted them to be evidence-based. We did a very thorough literature search from 2000 forward. 500 articles were reviewed. Three we were able to include because we were looking not at the offering of single preventive services, but more than one at a time. So the community guide, the CDC community guide, offers tons of evidence-based interventions for offering any cancer screenings or vaccines. We were looking at offering more than one in a community setting, and we came up with 3 that we highlighted. The report tells you everything you need to know and should invigorate your interest. One is around Spark, that's been going on for 12 years. We talk about who's been reached, the services that were offered, in what community setting, what contributed to the success, and resources that are available. We also highlighted the one called Wise Woman that is a CDC-funded program in 19 states, 21 programs, and 2 tribal councils. And what it is an add-on to the National Breast and Cervical Cancer program, and it offers cardiovascular screening support and gets individuals into activities, and it's specifically focused on low-income, underserved, and uninsured women. And the third is a study from Hopkins, the Family Health Study. So moving along, I just wanted you to be aware we have 5 appendices that provide a great deal of information. I'm moving you into the interactive version because it is fabulous and it will be a wonderful tool for all of you. We learned that we had some limitations in a book, just like you all have learned, and you can't quite include everything that you want, and you can't make it come alive in the way you want it. So we developed an interactive website designed to be user-friendly. I assure you, I have huge challenges with technology. I can find anything on it. It is fabulous. It includes not only national but regional data and selected state and local data. You'll see what we have for Texas. You can do comparisons, you can print reports, you can do cross-referencing, and it has all the resources to back up all of the indicators in this report, even those in the additional area, and you have links right to the websites. It's a great tool. So if you go to cdc.gov/aging, it's a feature there. And it'll take you right to this page. And you can see there's a map, and you can click right on Texas, and you can see that this is the Texas data for you, and it summarizes all the data for the state of Texas and each of the indicators. And then we also have metropolitan statistical statistical areas, and you can click on any of those and you get the same data when it's available. And in Texas, you have 6 of those, so it's just fabulous. And then if you clicked on pneumococcal, for example, you would get a graph that shows the age distributions for those that got the pneumococcal vaccine. And then if you actually clicked on one of the indicators, you'd get the data that's in the report, all the summary data, as well as the map or the graph that was included. So it is just a fabulous resource and can help you dig into what's going on in your county, your community, as well as the state and national. And then you can do comparisons. It does them for you. So you can put in up to 2 locations. You can put in a multitude of indicators, and it will print it out for you. Here's an example of what it would look like. So it just makes it so easy to get the data that you might need to better understand where the opportunities are or to justify why you'd want to put resources into something. Here's another one. Here's one for Houston and Dallas, and you can see the comparisons by age group. And the nice thing is that you can print out customized reports. You can go in and say, this is what I want, and you can click on, and on the, if you go, I'm going to go back. In this corner, you can click on all of each of these purple areas, and it'll show you what's in that area. But in the report, you can also include the information from that. So if you want to have the Healthy People 2010 objectives as part of your report, you can have that. So it's just a great resource to help you zero in on what might be important to you and what you want to think about with you and your collaborators to help bring preventive services to your community. So we have, it delineates the appendices that were in the report and gives you all the information. It provides background on each of the expert panel recommendations that we included in the report. It also highlights the spotlights that I just briefly told you about. And this resource section is fabulous. If you click on any one of these, it takes you to resources, and then you click on it again and it takes you right to the site. So I think I've talked about the ways that the report and the website might be helpful to you. And I think I've alluded to several of the things that are in the near future and coming to you that I might want to come talk to you about next year. One that we're hoping to get into clearance next week is the sequel to this report. Or when we started this, we thought it would be the first in a series. And they're a little different, but they're around preventive services. We've been working with DHHS, the Agency for Healthcare Research and Quality, Administration on Aging, CMS, and AARP on a report that will be released early in 2011 on enhancing the use of Medicare-covered preventive services among older adults. And it too will be an abbreviated, it's a much smaller report, but very targeted, full of wonderful information. So I'm really excited about that. And I mentioned that the State of Aging and Health, the website is updated every year with more current data. And AARP, as I said, has taken a great interest in preventive services, and their primary focus is on their members. And we've just recently, I think it's not quite out of clearance, we've developed a toolkit to help volunteers who might want to become more aware of preventive services and also to help others in their community become more aware. So it's all about screenings and immunizations related to that. And we've done several webinars on preventive services, and AARP will have has an ever-growing number of resources related to preventive services. I should have said this right in the front, and I'm humiliated. I I am here because Linda Anderson could not be here, who is the director of the Healthy Aging Program at CDC. She is the mastermind behind all of these efforts in promoting preventive services. She really wanted to be here but had a prior commitment. She is committed to preventive services. She has spearheaded both this report and the previous. And Maggie Moore, my colleague at CDC, is the person behind the State of Aging and Health and the website, and it's all of her good thinking, and she helped with the slides, and so I should have acknowledged them both right up front. And they are wonderful resources, as Michelle can tell you, who has worked with Linda. We have 4 minutes for questions, and if we can't have them now, I'd love to have individual conversations with you during the day, because I want Texas to play a big role in the future of getting those numbers up. Any questions?
I'm Josh Wiener, RTI International from Washington, D.C. So I have two questions. One, this notion of being embedded in a private organization is an intriguing one. Could you say a little more about the kinds of activities that you're doing with AARP? And then my other question is, the focus of what you've presented is really on the general population, but it's people with disabilities who have the lowest use of these preventive services and the highest healthcare costs. Are there any initiatives to try to target that population to try to serve them?
That was an issue that was raised in the steering committee, and again, data were, and if I'm remembering correctly, data were an issue in being able, because when we think of disparities, obviously disabilities, in terms of getting services, that was a big issue and of great concern to the steering committee. So it's something that we considered. We didn't have the data, and I actually think it might be mentioned in the additional issues on the horizon, things to think about. So I think you raise a good point, and one we don't lose from the back of our minds. It just we weren't able to feature it in this particular report for data reasons. You asked about the embedded, my position, and if we don't get time to talk about it, because I have 2 minutes, I'll tell you more individually. But as I said, I think I sit in the education and outreach area of AARP, which is a huge organization. I don't know if you know that, but thousands of employees. And on a day-to-day, I think with them on issues more than just education and outreach, on the policy issues, but we're working hard to figure out on, say, the policy and how to do that. And we have to be very careful because both organizations, especially AARP, works very hard to be nonpartisan. So it's the sharing of science. An issue comes up, and someone in the policy area is interested to know about workforce, what CDC knows about workforce and health, and I will contact colleagues in CDC. That's just, those kinds of questions come up all the time. We're doing a study from CDC, how can we access AARP members? Another area we're working with them on is messaging around preventive services. Each has very different strengths. AARP has a huge knowledge management area of research, and we're working with CDC to glean from their science and help structure the questions to better understand how to message around preventive services for the 50+. We're also working with a group that has gotten funding from RWJ to do the same. It's across the board. It's linking the various areas of CDC with various areas of AARP. And thank you for the questions. Thank you all. It's really been a treat to come this morning.
Buenas noches, iniciamos con noticias de última hora. Les saluda Brenda Jiménez.
Y Jorge Núñez. Pues ¿estará usted de acuerdo que nuestra cultura nos enseña a respetar a las personas de la tercera edad? Pero no siempre es fácil cuidarlos durante la etapa de la vejez.
Por esa razón, líderes en el campo médico se reunieron bajo el mismo techo el día de hoy y Anabel Monge nos explica más.
Así es, Jorge Brenda. Según los expertos, el cuidado para las personas de la tercera edad puede convertirse aún más difícil si ellos viven con algún problema físico o quizá alguna enfermedad. Para la mayoría de las culturas, los abuelos son preciados miembros de la familia, pero a la vez todos sabemos que el envejecer no siempre es fácil. Esta etapa puede llegar a ser más frustrante cuando la persona de la tercera edad vive con problemas físicos o demencia.
Comunicando con una persona o diciéndole que necesita ayuda o que quiere comer, por ejemplo, puede ser algo bien difícil para una persona que tiene la enfermedad.
Los expertos indican que los problemas físicos y el dolor crónico disminuyen las capacidades y aumentan el estrés y la ansiedad, no solo para el paciente, sino también para la persona que le está prestando cuidado médico o emocional.
Y es muy importante que las personas que los cuidan, que se educan sobre la enfermedad y qué pueden hacer.
Con la meta de educar a la comunidad y en especial a los integrantes del campo médico, hoy viernes en San Antonio se realizó un foro informativo donde mediante discusiones detalladas se habló sobre las diferentes enfermedades que afectan a las personas de la tercera edad y cómo sobrellevarlas.
Es muy importante educarnos, saber qué podemos hacer, saber que conectamos con la Asociación de Alzheimer's, en conectarnos con tipos, con grupos de apoyo.
Y bueno, aunque este foro informativo se realizó aquí en el centro de la ciudad de San Antonio, la sesión contó con la presencia de varios expertos de a través de toda la nación. Anabel Monge, Noticias 41.